Hello, my name is Mohammed Sarich. I'm Director of Non-Invasive Cardiology and Professor of Medicine at New York University. And here's my presentation on handheld ultrasound imaging. These are my disclosures. What is handheld ultrasound, which is often referred to as POCUS or point-of-care ultrasound? The POCUS is a bedside imaging, ultrasonography brought to the patient and performed by the provider in the real time, and that allows for immediate image acquisition and interpretation. That is to say, there are real-time dynamic images that can be interpreted promptly rather than recorded by a sonographer and interpreted later. And also, the image is interpreted in a clinical context. Images can be directly correlated with the patient's clinical status, making a significant advantage to POCUS imaging. The American Society of Echocardiography has guidelines for POCUS imaging and in the context of critical care echocardiography training, and that's the guidelines from 2020. Also, there is an American Society of Echo-POCUS reference that you can take a course on cardiovascular point-of-care imaging for the medical students or novice user. What are the key elements of a POCUS study? First, we have to have a handheld ultrasound device. Then we have to broaden our diagnostic scope away from just imaging the heart, but the imaging other organs as well. And then the POCUS is also characterized by ever-expanding group of practitioners who are involved in acquisition and interpretation of ultrasound images. And then there is an use of artificial intelligence in the current and future POCUS devices to simplify and speed up the interpretation of images. Let's look at the POCUS equipment. And you know, most of us are echocardiographers and we use the full-size ultrasound images in the lab, or we can do some portable exam using portable ultrasound system. However, there are dedicated POCUS exam equipments, which are handheld exam, here one from GE. However, other manufacturers, mainstream manufacturers also have POCUS dedicated equipment, such as a GE V-Scan or a Philips Lumify and a Siemens P10. In addition, there are newcomers to ultrasound manufacturers, such as the Sonosite, which has been present for a long time in particularly in the critical care and the emergency departments, and also the Butterfly system, which is a completely new way of acquiring ultrasound images. Now let's look at the POCUS practitioners. Who are the POCUS practitioners? So echocardiographers, internists, medical students, but also critical care specialists, emergency department professionals, pulmonary critical care professionals, as well as this anesthesiologists, in addition to cardiology specialists. And all of these specialists are now eligible to take the critical care echo board exam. And the first exam that we created was in 2019. And now we are already in the third iteration that was given in January 2021. So if you're interested, we give it annually, and in January 2022 will be the next exam. Now let's look at the POCUS diagnostic scope. It's cardiovascular ultrasound, but also extracardiac ultrasound. And it's probably the major difference between what we have traditionally done in the echocardiography lab and in the context of POCUS is different. So the cardiovascular ultrasound is primarily in the context of echocardiography lab, but the extracardiac ultrasound is as important as cardiac imaging in the context of POCUS imaging. And particularly with respect to extracardiac ultrasound, we have to become familiar with the concept of lung ultrasound. Let's say that we have a 65-year-old man with hypertension who presents with a sudden onset of chest pain and abdominal pain. can we use the POCUS at the bedside to quickly deduce what the diagnosis is? And this is one of the studies that I did back in 2008, more than a decade ago, with a handheld device, and you see there is the aortic dissection. So it's a very simple, at the bedside, we see maybe the explanation for the patient's chest and abdominal pain. How about the lung ultrasound? Shortness of breath is the leading presenting symptoms to the echocardiography lab or to a physician or emergency department. Surprisingly, lung ultrasound has not been part of a standard echocardiogram. And that all has changed with the pioneering work by Daniel Lichtenstein, who was a French clinical care physician. And back in 1995, he used bedside ultrasound to rule out pneumothorax in a critically ill patient. So there was, and he came up with the concept of lung sliding and see whether that can help us in determining if a patient has pneumothorax or not. Interestingly, he relied on a prior report about it 10 years earlier from a veterinary medicine where another person used bedside ultrasound to diagnose a pneumothorax in a horse. And then Daniel Lichtenstein went on to determine other aspect of lung ultrasound beyond pneumothorax. And here he's talking about the Comelter artifact allowing for the diagnosis of alveolar interstitial syndrome or edema inside the lungs. But let's look at the basis of lung ultrasound by POCUS imaging. Remember, lung is an air-filled organ, and unfortunately, air is a poor conductor of ultrasound. Remember that the velocity of ultrasound in the human body is about 1540 meters per second, close to pure water, and in air, it's only 1/5 or so. And also the impedance is much, much less in the air than it's in the water. And so probably that's the reason why the echocardiographers, we didn't look at the air ultrasound or lung ultrasound as a part of a standard exam. But it all changed with Lichtenstein and his fellow. Extracardiac ultrasound then can be used to image the lung tissue. Interestingly, lung ultrasound imaging often relies on very creative interpretation of ultrasound artifacts. And if you're interested in the spectrum of all the ultrasound artifacts, my colleague and I recently published a review article on ultrasound imaging artifacts, how to recognize them and how to avoid them. In echocardiography, we try to avoid artifacts, but in lung ultrasound, we actually welcome them. And let's see how that's done. First, if you would like to image the lung with the point of care ultrasound, there has to be imaging windows. Just as in echocardiography, we have cardiac windows that are lung windows. And there are 3 such representative sites where we do lung ultrasound. And let's see what we can deduce from lung ultrasound imaging. Let's start with recognizing the pleural line. This is a normal ultrasound and how we see the pleural line on it. We can do imaging of the lung with the vascular probe, we can do with the cardiac probe, but also we can use the M mode on the right-hand side. And on the left-hand side is using the vascular probe. And see the pleural line on the vascular ultrasound imaging, as well as the pleural line of the M mode in a normal person. If I put video on, this is now you can see the lung sliding of the pleura, a normal finding. And again, this is using a vascular probe. Let's compare this to somebody with the pneumothorax. Now, there is no longer lung sliding at the imaging window that we chose. So now let's compare side by side. Normal lung sliding on the left, there is a movement of the pleural line, as opposed to the absence of a pleural line movement that it's part of the diagnostic spectrum of a pneumothorax. Now let's summarize the additional finding, particularly in the M mode, and a normal finding of a SAND as opposed to a barcode sign in a pneumothorax. Now let's switch gears to the A lines. What are the A lines on the lung ultrasound? Those are lines that are normal finding on a lung ultrasound. On the left-hand side, we'll have imaging of the lung using phase array probe and then corresponding CT scan image of a normal lung parenchyma. And A lines are considered reverberation artifact. They are equally spaced, twice as deep from the next one. And now let's summarize them. A line, there's a horizontal line. They are repetitive, evenly spaced, and likely represent reverberation artifact. The source is the pleura, and they are present in a normal lung as well as in pneumothorax. So let's look at them on a live video clips. So these are A-line reverberation artifact from the pleura, evenly spaced in a leather-like, with a leather-like appearance. But what about the B lines? Are they normal or abnormal? Let's look at them. So these are the B line on the left-hand side, acquired using a phased array probe and corresponding CT scan in a patient with pulmonary edema. So B lines are considered comet tail artifacts as originally described by Dr. Lichtenstein, and they are present among other pathologic conditions is the alveolar interstitial syndrome. Now let's look at this on a live video clips. Those are B lines moving from side to side, are considered comet tail lines and are present in alveolar interstitial syndrome. That is to say, when the alveoli are filled with fluid, whether due to cardiac disease or intrinsic lung disease. And now we can compare B lung ultrasound versus chest x-ray. Interestingly, B lines on ultrasound tend to correspond to curly B lines on x-ray. This is probably just a pure coincidence that the two different imaging modalities decided to use the term B lines for the same anatomic finding. And this is Sir Peter Curley, Irish-born British radiologist, who described them on x-ray imaging. So now let's summarize the B lines. How do they appear? They are vertical lines, they are repetitive, extended full length of the screen. They move in concert with lung sliding, and they obliterate the A lines. The cause is likely the reverberation artifact that you saw. It's possibly a comet tail, and they're present in conditions with high impedance mismatch at air-fluid interface. Therefore, B lines are characteristic of congestive heart failure, ARDS, lymphedema, pneumonia, lung fibrosis, and lung trauma. Let's now switch to pleural effusion. Can we use POCUS to visualize the pleural effusion? And yes, we can. So see, that's a pleural effusion. Again, on the left-hand side, we're seeing a phased array probe, and on the right-hand side, corresponding CT scan in a patient with the large right pleural effusion and compression of the adjacent lung tissue. Again, this is a live video image. There is the liver, right costophrenic angle, pleural effusion, and the compressed lung. How about the use of POCUS for congestive heart failure? Let's take an example. A 65-year-old woman presents with dyspnea and a normal left ventricular ejection fraction. This is a panel of 4 images from one of our publications. On the top, there is a Doppler imaging. Top A, or panel A, is mitral blood velocities. Panel B is mitral tissue velocities, while C and D represent POCUS imaging. So from the top 2 panels, we can deduce that there is elevated left atrial pressure with a very high E over E prime ratio of almost 32. And then on POCUS imaging, we can recognize there is a pulmonary edema due to presence of the B lines, and there is a pleural effusion. So therefore, using both the echocardiography and the lung ultrasound, we can deduce right at the bedside of this patient that the dyspnea in her is due to heart failure with preserved ejection fraction. How about another pathology, lung consolidation such as pneumonia? 60-year-old man presents with dyspnea and a normal ejection fraction. Does he have a heart failure with normal ejection fraction, or maybe shortness of breath from something else? Again, we will use the phased array probe on the left. We'll show the fusion, consolidation, but also on the right-hand side, we will something new, which is called air bronchograms. And then here, these are bronchograms, which is a characteristic finding of lung consolidation in pneumonia on POCUS ultrasound. So in this patient, that we can say that the dyspnea is likely due to pneumonia rather than a heart failure with preserved ejection fraction, as we had in the case before. So additional finding in pneumonia, B lines are present, there is a pleural effusion and absent lung sliding. How about COPD and asthma? Let's look at the ultrasound in those two conditions. So in COPD and asthma, there is a predominance of A lines, there is normal lung sliding, there are absent B lines, and there is no lung consolidation unless there is a superimposed pneumonia. And for COPD and asthma, we often use the so-called FALS protocol. What does the FALS acronym stand for? It's a fluid administration limited by lung sonography protocol. It's an integrated echographic and lung ultrasound assessment of a circulatory shock. And these are the four primary forms of circulatory shock: tamponade, pulmonary embolism, tension pneumothorax, and pulmonary edema. How about integration of POCUS with artificial intelligence? As I pointed out, the bedside ultrasound or handheld ultrasound is being used by ever-expanding number of medical professionals. Some of them don't have a official training with the ultrasound. And how can we help them with artificial intelligence to acquire good images and how to interpret them correctly? And this is where the artificial intelligence come into our help. Here's a POCUS ultrasound imaging with artificial intelligence software on top of it. So here you can see that there is a diagram that tells us where exactly a performer needs to place the ultrasound probe in imaging the heart. So then there is also the ideal image that should be obtained. And now there is also a bar chart that the higher the number of bars, the closer the imager is to the ideal probe position. So here, and can tell you, the system can tell you rotate slightly counterclockwise, clockwise or counterclockwise, whether to move the probe laterally or medially, and essentially guide us to perform a correct ultrasound imaging, in this case of the heart. And then again, this is the bar that tells us how close we are to the ideal probe position. And on top of that, when we acquire image correctly, the system can automatically calculate certain parameters, in this case, ejection fraction, which is probably the most commonly used parameters of all of echocardiography. Now let's look at the POCUS during COVID pandemic, where the POCUS truly shined, where we were all concerned about the exposure of ultrasound imagers to COVID positive patients. So my colleague and I, we published a review article and our experience of point of care ultrasound during COVID pandemic. And it was online available as of January of 2021. And I'll show you one example of such use of POCUS in a patient with COVID-19 who happened to have thrombosis. As you know, this was a 34-year-old man presenting with all the characteristic symptoms of dyspnea and low oxygen saturation. So upon admission, he was intubated and mechanically ventilated and had all the markers, inflammatory markers characteristic of a COVID infection. Chest X-ray, there was clearly findings of diffuse bilateral patchy air praised capacities consistent with the COVID-19 pneumonia. On hospital day 4, patient developed supraventricular tachycardia and hypotension. My colleague took point of care ultrasound and obtained the following images. Right at the bedside, patient is hypotensive. Can we tell why that patient is hypotensive? And here, maybe we can have an explanation. This is the imaging primarily of the right heart. You said there is a dilated right heart. And if you pay attention to the right atrium, there is a tumbling echo density, which represents clot in transit. In addition, there is a McConnell sign characteristic of acute pulmonary embolism. So severely hypokinetic right ventricle, except in the apical portion where contractility is preserved, characteristic of a McConnell sign. What's the diagnosis? That's acute massive pulmonary thromboembolism, and the patient is then treated accordingly. So this is the advantage. We have a highly infected patient right at the bedside. We obtain quick diagnosis without transporting patient to any other department. We also did the TE just to confirm, and you see this is a clot in transit in the right heart. It's a tumbling sausage-like echo density. And this is large during the different parts of the cardiac cycle during chest compression that we performed. And if you look at the frozen images, this is a clot in transit in the right atrium and the right ventricle. This truly demonstrated the power of the initial use of POCUS to establish the diagnosis. And we have published recently this case if you would like to have more details. So conclusion, so hocus pocus, the genie is out of the bottle. POCUS is here is to say, let's all become familiar with it. I hope you enjoyed this presentation, and thank you very much for your attention.